My name is Dr. Robert Higgins. I'm a member of the Society of Thoracic Surgeons leadership team, and we're assembled here today with experts in the area of global reimbursement for cardiovascular and thoracic surgical procedures. We're hoping to shed some light on a recent legislation that has occurred at the national level, which is impacting every one of our cardiovascular surgical team, and we're hoping to shed some light on some of the recent policy and the implications for us going forward. I'm assembled here with a panel of experts. I'm going to ask them to introduce themselves, and we'll start our conversation. Dr. Speir?
Good morning. I'm Alan Speir. I'm a practicing cardiac surgeon for the Inova Health System in Falls Church, Virginia, and I'm the chair of the Workforce on Healthcare Reform and Policy.
I'm Dr. Steve Lahey. I'm the chief of cardiothoracic surgery at the University of Connecticut, and I'm on the workforces for health policy and also for coding and reimbursement.
And I'm Dr. Frank Nichols. I'm a general thoracic surgeon at Mayo Clinic in Rochester, and I chair STS's Workforce on Coding and Reimbursement, and I'm your CPT advisor. So I'm an advisor to the CPT panel about coding issues.
So, Dr. Nichols, the recent legislation has had a number of important implications for us as cardiothoracic surgeons. Would you like to summarize maybe how we should be thinking about it in the simplest terms so that we can move forward with effective interventions to change and or influence policy going forward?
Well, I think the most pressing thing that's on our radar right now has to do with the 90-day global. And as many members might have heard, there's a whole discussion back about a year or so ago about CMS eliminating global payments, okay? Payments for 10-day procedure or 10-day global periods, 90-day global periods. And we thought that was really going to be devastating for the care of our patients, for the coordinated care of our patients and all sort of outcome type things. So legislation, STS was very helpful with that, getting to Congress, and legislation prevented the global periods from going away. But in that legislation, CMS was actually told they have to see if the visits, okay, that happen that we're supposed to be providing in our post-operative care, if those visits are happening. So what CMS is now doing is trying to figure out how to ascertain are the visits happening, and that's the challenge before us right now. And that's happening through either administrative data. There have been a number of calls and listening sessions with CMS about that, where they're at least gathering information from various specialty societies and the Relative Value Update Committee. But it also may come from a survey that the RAND Corporation has been hired by CMS to do.
Right. Well, it's clear that cardiothoracic surgeons are responsible for the care of their patients from the time they leave the hospital until the time that they fully recover. And the influence of the Society of Thoracic Surgeons has been really remarkable in terms of helping to find favorable decisions regarding these policy implications. Dr. Speir, can you talk about the role of the Society of Thoracic Surgeons in advocating on behalf of its constituency and, most importantly, its patients?
Yes, thank you. We were advised in July of 2014 that CMS was going to do away with our global reimbursement. Intrinsic with that, we then met with the leadership, we being the leadership of the Society of Thoracic Surgery, met with the leadership of CMS as well as our government relations advocate, Courtney O, to then present with them the disruption and that this global dissolution might have to both accountability and attribution of how we practice the follow-up care of our patients, as well as then the contribution to our database. We then presented before Congress with the Energy and Commerce in February of 2015 and made the plea on part of the Society of Thoracic Surgery, really what the globals meant to us, the strength of the database and how we care for the patients. And then we're actively involved with the leadership in Congress to order to effect change and present what the bill should maintain, both not only the dissolution of the sustainable growth rate, but also the maintenance of the global itself.
Well, this activity clearly was a win for our patients and may have a far-reaching impact beyond reimbursement. But Dr. Lahey, maybe you can talk about what we as surgeons can do to influence this policy-making process going forward, because it really is about patients and advocating for them, as well as for our profession, which has been so effective in saving hundreds of thousands of lives.
Right. Well, I think that we're actually positioned pretty well because, in general, cardiothoracic surgeons really lead all surgical subspecialties in intense, personalized, daily care of our patients. And this is well known, and this is why we've enjoyed enormous credibility at the Relative Value Update Committee, where RVU valuation is established. I think the important thing that we have to realize as practicing cardiothoracic surgeons moving forward is this is a very, very critical moment for us. And we need to educate the members to understand the importance of this. And as much as we hate to say it, it's going to require now, for the first time, documentation of work that we've always done. This isn't the most pleasant thing in the world, but unfortunately, CMS and HSS has been directed to not only record how many times we visit these patients, but as far as I'm concerned, the difficult thing is the intensity, the level of the service delivered in the postoperative period. We're not very good at judging that, and we're going to have some understanding of that. As far as the number of visits, boy, we're in really good shape because we have the advantage of the STS database, and so people know that the STS can give very, very accurate data on how many times we see these patients. We know the length of stay. And we know if you know the length of stay and you know you see the patients every single day, we're probably going to be okay because we could then tell CMS or BARD, the RAND group, when they ask us, we can say, the patients are seen the day of surgery, a critical care visit, which means, we all know what that means. Right. They're very sick, they require a lot of work, there are a lot of time there. And then each day, we see them every single day, we know what the length of stay is, so right away we have an understanding of what the number of visits are and the level of visits. It gets less and less intense as you go along. People get very, very frustrated trying to talk about the individual CPT codes. When we start saying the various code numbers, it becomes very, very arcane and difficult to understand. But the important thing is just to be honest. If you're surveyed, say how many times you see the patient, what do you do on each one of those days, and it probably is going to work out because we're all very well prepared already.
Well, that's great. I think the take-home message then for me would be we already do the work. Documenting the work that we do to help patients improve after surgery is critical, and that will be an important aspect to prove our added value to this care patients. I would also ask, what the future holds. We're coming from some states now which are bundling payment to include all professionals who are participating in the care of a patient with a cardiovascular or thoracic illness. Can we start to explore some of those methodologies because they are going to have an impact in places like Maryland where hospitals are getting paid in a bundled arrangement for all of the care that both surgeons and other physicians, participants provide. And that's going to be a new burden on us as a specialty and as a profession. So maybe we can speak about some of the evolving strategies that are coming down the pipe.
One of the critical parts of the MACRA bill as directed through Sylvia Burwell, the Secretary of Health and Human Services, is that 30% of reimbursement will be in an alternate payment method. You alluded to one with global pricing, but it could be extended fee for service, pay for performance. This is expected to be by 2017 or 2018, 50%. And so the Society of Thoracic Surgery is really taking a leadership role and looking. We have already written a provisional white paper about the types of alternative payment that are available. We're going to be expanding those to then be made available to our members and give examples and counsel, whether it's through webinars or meetings, in order to educate better what they can do with their colleagues within their institutions is to be prepared for this. I think it's also expected that we will be expanding their education in the E&M codes that my colleagues on the panel are vitally familiar with, but that surgeons have not thought in that way, but may need to be thinking further in that regard. So I think within this calendar year, this alternative payment types will be presented to you and the other leaders of the STS. We're working very quickly at giving concrete examples and how to educate our colleagues further.
Well, this certainly is a brave new world for cardiothoracic surgeons who've been mostly taking care of patients. Worrying about reimbursement and documentation, as well as payment methodologies, is not necessarily our forte, but it's critically important to us to be involved. Maybe Dr. Nichols, you can talk about the engagement of our local groups to help educate surgeons about the importance of these initiatives coming down the pike.
Well, we're going to take a renewed effort, okay, I think between our workforce coding workshop. Now, the coding workshop that STS runs happens in late October, November of each year. Well, that's going to be too late this year. So we're going to have some other educational efforts, okay, quicker and early on. I think the big thing as I look at the immediate challenge is this 90-day global, okay, searching for are the visits happening by CMS. And while it's important, okay, for the doctors to document their work with the patient, it's also important, though, that the doctors' work or the relationship they have with their NPPAs and residents, okay, also be well documented. Because the work, okay, is sometimes collaborative work. Now, we're not talking about collaborative work between the cardiologist and the cardiac surgeon. We're talking about the immediate patient's care provision team, you know, the NPPAs, residents, et cetera, and the relationship there. And documenting, I think, Alan, I think you're making a real push for even just doctors signing the notes or counter-signing the NPPA notes, things that maybe historically we've done, gone by the wayside a little bit, doing more of that now. That's our short-term goal.
Dr. Higgins, just to expand that thought, I think it's important for our membership to understand that it is to date a little bit unclear as to how CMS is going to access our records and review such records. However, up to 5% of our reimbursement can be withheld for episode of care unless these records are made available. So if CMS formally is requesting any of our membership to provide information or counsel to them, that it is vital that they do so. And to underscore what Dr. Nichols alluded to, we're just, and you both have said this, but to underscore, it's not important to be doing more than we're doing just to make our presence known. Whether it's signing the resident notes, the PA notes, the nurse practitioner notes, it is going to be more than just being available on our operative notes, rather just showing what we do every day, many times a day.
And in that legislation, just talking about the withhold, I mean, that's a very important point, Alan. There is a withhold, a 5% withhold that if we don't provide this or the providers don't provide that. The American College of Surgeons, STS, a number of other specialty societies on a recent listening call with CMS, they were listening to us, gathering our opinion. We're very adamant about the fact that this should not be punitive. They want the data, we want to work with them, provide the data, but it shouldn't be under the threat, you know, of another 5% withhold.
Sure. And the STS has also taken a leadership position with the American College of Surgeons and the cardiologist within the House of Medicine, being available to be resources for each other as well as to CMS.
Well, it's fantastic to know that we have thought leaders in this area assembled within the STS, as well as with our leadership team in Washington, advocating on behalf of cardiothoracic surgeons and patients. Dr. Lahey, maybe you can talk about the added value. Maybe these activities, even though it seems onerous, will in fact help us as a discipline and help our patients going forward.
Well, that's a very, very interesting question, because one of the things that may actually happen if CMS or the RAND Corporation, and we're equating the two because they've been contracted, RAND has been contracted by CMS, but if they were to really get accurate data on what we do, it may be a situation where you're hoisted by your own petard, because we know when you do a cardiac operation or a thoracic operation and that patient is in the ICU that night, we've only valued the total RVUs based on one visit that day. Do you see the patient once a day? Of course not. We don't do that. We see the patient, the next day we'll see him in the morning on rounds, formal rounds. In the afternoon, we may be on our way to the cafeteria and we stop off the ICU. Then at the end of the day, we see them. We actually see them more than what is actually embedded in the total RVU valuation. So if they really want to get accurate data on this, and we send in all the times that we see them, it might be a very, very interesting time for CMS, because they may think like, gee, they're being underpaid. Sure. I don't think that's going to happen, but it's an interesting concept.
Dr. Higgins, I think your question, though, has brought us full circle, because as we started out talking about the global payment, who knows the cardiac surgical patient, the cardiothoracic patient, better than the surgeon themselves? And we cannot allow within our institutions and in any way that we abdicate the care wholly to the intensivist or to the hospitalist. We need to maintain the care of those patients, and of course there is a percentage of patients that will have multi-system failure or adjunctive medical conditions in which the visits by those consultants will be additive, not duplicative.
That is a key issue that everybody has to understand, that the service we provide, the critical care service, is not duplicative. We want intensive care people, they can take care of the acute kidney injury or whatever, but for the purposes of justifying what we're doing to CMS, we must say that what we're doing is unique care based on our training and specialty. It is not the same as the intensivists, and it'll be critical to get that concept across.
That's great. Well, I'm optimistic that with thought leaders like the people that are assembled here and our advocacy efforts in Washington, that the STS and cardiothoracic surgical disciplines will rise to the challenge by documenting the outstanding care they've provided over the years, the great outcomes that we know that the database demonstrates in terms of cardiovascular mortality and morbidity, that this is an opportunity for us to really shine. And I look forward to engaging the RAND Corporation, CMS, in the discussion with folks like you at the table. I think we've got a great chance to influence national policy and direct the future for our patients and enhance their outcomes. So we really want to thank all of you for participating. I think this is the start of an important conversation, and we hope that the rest of our membership will engage and learn from it, and hopefully advance the cause of cardiovascular disease in the future. So thank you so much for your participation.
Thank you.
It was great.